Okay. Okie dokie. Well, I guess we will get started and hopefully people will join us. Good afternoon, everyone, and thank you for joining us for the second in a three-part series on the role of lobbyists in shaping healthcare policy. The last forum will be September 23rd, where we'll explore the 88th legislative session and what's on the docket for there. I'm Rebecca Lunstroth with McGovern Center for Humanities and Ethics, and today's panel is sponsored by UTHealth's Quality Enhancement Program titled Health Policy for Health Professionals, or HP Squared. Our aim is to enhance the health policy education of all of our learners, and this is one of many opportunities you will have to learn about how policy influences your profession. Before I introduce our moderator, I'm going to ask you to answer a question before and after today's discussion. They are anonymous. Additionally, you're encouraged to pose questions in the chat, which we hope to address. I'm thrilled to introduce today's moderator, who is Kara Crawford. She is the VP of Governmental Relations at UTHealth Houston. And in this capacity, Kara is responsible for overseeing day-to-day operations of UTHealth's governmental relations activities in Austin. So she's actually housed in Austin, Texas. And there she fosters relationship with state and federal elected officials, staff, and agencies to advance our programs and priorities. Kara joined UTHealth in 2018 following a decade of service as a budget and policy advisor in the Texas Senate for Governor Greg Abbott's administration and as chief of staff at the Texas Health and Human Services Commission. Kara earned a bachelor's in communications from Kansas State University and a master's degree in public administration from Texas State. She loves living in the Hill Country. I'm a little envious of her. And on behalf of the QEP team, I want to thank Kara and her colleague Scott Forbes for helping to arrange these sessions. So Kara, it is all yours. And thank you again.
Great, thank you, Rebecca. Well, as Rebecca mentioned, our previous panel really talked about the role of lobbyists in the legislative process. And now on this panel, we're going to take a deeper dive into some actual policy discussions. So this most recent session had its own unique challenges. Every session does. The backdrop going into this session, as you all know, was COVID-19 and a pretty impactful ice storm. But despite those issues in the background, I think we still managed to move some really important policy, particularly in healthcare, around access to healthcare, behavioral health, public health, and telemedicine. And speaking of advancing important legislative topics, we have three wonderful panelists here today that are experts at doing all of these things. So let me introduce them briefly. Our first panelist is Jamie Dudensing. Jamie is the Chief Executive Officer of the Texas Association of Health Plans. As an advocate for public and private health plans, Jamie is dedicated to improving access to quality healthcare for the uninsured and committed to enhancing consumer choice and the affordability of health insurance for all Texans. Jamie is a graduate of both the University of Texas LBJ School of Public Affairs and Texas Tech School of Nursing. She began her career in Austin after being recruited to become the Capitol Nurse, which is a wonderful little factoid about Jamie. After gaining her master's in public affairs, she served 2 sessions as the Health and Human Services Budget and Policy Analyst for Appropriations Committee. And then she joined Lieutenant Governor David Dewhurst's staff for many years, where she first served as Senior Advisor for Budget and Policy, and then as Deputy Chief of Staff and Policy Director. So with almost 2 decades of engagement in healthcare and appropriations policy, Jamie provides TAHP with an extensive record of coordinating legislative strategies, testifying before legislative committees, and working closely with state agencies and elected officials to create sound policy. Our second panelist is Lindsay Lanagan. Lindsay is Vice President of Government Relations and Public Affairs for Legacy Community Health Services. In her role, Lindsay oversees federal, state, and local government relations for the organization to influence policy at all levels of government, and leads the public affairs team. Prior to joining Legacy in 2018, Lindsay was senior manager for state government relations for McKesson Specialty Health, one of the nation's largest healthcare companies, where she directed state policy for a 23-state region. Lindsay previously led the City of Houston's Intergovernmental Relations Office, where she oversaw local, state, and federal government relations for the largest city in Texas. Prior to that, she served in the mayor's office and worked on multiple political campaigns and served as a staff assistant in a congressional office. Thanks for being here, Lindsay. And last but not least, Eric Woomer is also joining us today, and he is a governmental affairs consultant and lobbyist with extensive senior leadership experience advising legislators at the state and national level, as well as business interests ranging from Fortune 100 companies to trade associations to family-owned businesses. Eric served as chief of staff and ledge director to 3 Texas state senators, representing areas as diverse as the Texas Panhandle to the Houston Ship Channel. That's a lot of ground. Additionally, Eric served as press secretary for U.S. Congressman Jake Pickle and as senior policy advisor to U.S. Senator Kay Bailey Hutchison. In 2010, Eric founded Policy Solutions, which is a full-service public affairs and consulting practice based in Austin. Eric offers his clients legislative guidance and policy expertise on matters related to energy and water, natural resources, economic development policy, state budget, and of course, healthcare. Eric received his Bachelor of Arts degree in government from UT, and then his master's from the UT LBJ School of Public Affairs. So with those intros, we have an all-star panel. Thank you all 3 so much for being with us today. And now we can dive into a conversation about the most recent session and some policy. So first, just to give our students and listeners a feel for who you work with, if you could each give us a brief overview of who your clients or membership for your associations are and what their top priorities are. And whoever wants to dive in first, go for it.
I'm happy to go first just because I think I'm hyper localized and you guys do more statewide. So I work for Legacy Community Health. To explain kind of what a community health center is, it's just a word soup of, we're a federally qualified health center. So if those aren't familiar with a federally qualified health center, essentially you have independent physicians' offices, you have hospitals, and then you have this thing in the middle, it's called a community health center that treats anyone who walks through your door, regardless of your ability to pay. But you essentially go to the federal government and you say, we want to serve this underserved area. And so we end up treating, we must provide primary care. We must have a board that is run by 51% patient population. And so it's really the closest thing you'll see to treating the uninsured for primary care, behavioral health, vision, dental. So Legacy operates in Houston. We go to Baytown, Deer Park, Beaumont, and now we're in Stafford and Missouri City. And so it's kind of that Southeast Texas region. Our community population is largely minority, largely underserved. 99% of our patient population is within 200% of the federal poverty line. And we are heavy in pediatrics and OB-GYN. So we treat about 350 pregnant women a day. And most of those women are on Medicaid. And so our policy priorities are largely around Medicaid coverage. I think Jamie and I spend a lot of time talking about extended coverage for mothers on Medicaid, and we can get into that and the successes that we had this session. But also things like mental health coverage. That's a massive part of what we do. We have 93 employees that are psychiatrists and psychologists within our organization, and our waiting list is still in the hundreds because there are not a lot of options for underserved communities for mental health coverage, and also telemedicine. So those are our top 3 priorities.
Great, thank you, Lindsay. That gives us a good feel for who you're working for and representing. Jamie, do you want to give us a little overview for THP?
Yeah, as Kara mentioned, my name is Jamie Dudensing, and I run the association called Texas Association of Health Plans, which represents a number of different types of health insurers that provide coverage to more than 20 million Texans in Texas. They are the ones that provide coverage in the employer market and the individual market, the ACA market, for Medicare Advantage, and of course, Medicaid managed care. So we see all the different types of issues as they come together across multiple types of Texans and populations in different areas of the state of Texas, and different issues that are happening across the board. So we get pretty involved in almost every single healthcare bill that's going through the Capitol some way or another as a result of that.
Great, thanks, Jamie. Eric, do you want to give us a little overview of some of your health-related clients?
Sure. Thanks, Kara, for having me, and I appreciate being included. I'm structured a little bit differently because I'm an independent lobbyist, and so I have kind of a variety of clients, but I'm not in-house. I don't work for one particular interest. On the medical side, I have a lot of provider groups. I represent the Texas Pediatric Society and other pediatric providers. I represent the Federation of Texas Psychiatry, which is the Association of Psychiatrists. I represent the Texas Dermatological Society, as well as the Texas Association of Ambulatory Surgery Centers, Home Care and Hospice Association. And then I do a fair amount of work on the pharmaceutical side too. I represent an organization called BIO, which is a big multinational organization, represents well over 1,000 companies. And they do not only pharmaceutical research, but also, anything related to the biosciences. So food additives, fertilizers, things of that nature. But a lot of it is related to pharma. I also do work in a variety of other areas. Construction is a pretty significant part of my practice. I represent Expedia. You mentioned the winter storm. I represent a group of electric wholesale generators, as well as affordable housing providers and DraftKings and several other clients. But a big part of my focus is medical and bioresearch.
Great, thank you. Well, I feel like we have a diverse group here, everything from, as Lindsay said, kind of hyper local to statewide and everything in between. So thinking of the issues that are important to your clients, we thought we would kind of flip this for this first question and just talk about from the consumer or taxpayer's perspective, or even a patient perspective. What do you think were some of the biggest issues the legislature confronted last session and hopefully dealt with somewhat successfully from a consumer or patient standpoint? Lindsay, do you want to go first?
I'm happy to.
Might as well.
Happy to. Well, I would be remiss if I didn't also mention, so we are the largest community health center in the state of Texas, but we're also the largest Ryan White clinic in the state of Texas. And so we treat about 5,000 individuals living with HIV. We concentrate a lot on HIV prevention as well. So just know that I'm speaking also from that perspective when I say the things that we concentrated on last session from a consumer perspective. We were seeing a huge influx of unemployment in a ton of different spaces, but for us, that meant a very large influx of uninsured patients, especially uninsured HIV positive patients. So we found ourselves in a real struggle for HIV funding, and we really wanted to make the case that you can't have a pandemic within a pandemic. And so we had to go for additional funding last session to make sure that people were getting the medications they needed in order to be to maintain a viral load that was suppressed. And just to provide some stats, 12 people a day are diagnosed positive with HIV in Texas. That's around 4,800 a year. Those are largely in underserved areas and largely uninsured patients. And so from the consumer perspective, it is incredibly important that these patients and individuals living with HIV are virally suppressed so that there is no transmission. The other huge things that we worked on last session And this was a very big collective effort, but one that was so meaningful to my patient population, is that previously, before last year, Medicaid moms, women on Medicaid, they only had 60 days of coverage post-pregnancy. For us, that is not enough time. We definitely treat a high-risk patient population when it comes to our pregnant moms. We really were shooting for a year of coverage postpartum. And that's really the standard in most states and most state Medicaid programs. And so we made a big case, at least from Legacy's perspective, along with a huge coalition. I know Jamie was really involved. I think this is something that they had on their priority list as well. We were able to get 6 months postpartum coverage. That extra 4 months is massively important to my patient population, because we see more than 300 pregnant women a day. So we absolutely needed that. The other thing that was just seemed like such a simple fix, but was such a huge thing for us, is that at every single one of our facilities, we employ about 9 people that sit there all day long and meet with patients about what options are they eligible for, right? Because if you try to call the state Medicaid office, it's really difficult to sign up for these programs. And so we have dedicated individuals, they're called eligibility specialists, that sit with our patients and really work them through the system in order to get the benefits that they're eligible for. We were finding that children were just getting dropped off of the rolls repeatedly, and they'd have to come and sit down again with our eligibility specialists, because the way that the state was administering children's Medicaid was essentially they would send a letter that you had to prove your eligibility, and you had to reply within 10 days of receiving that letter as to whether or not you were still eligible. And that was happening like 5 times a year. Jamie, you can correct me, but it was something like at month 1, and then 5, 6, 7, and 8. We were able to streamline that a little bit. And so now they're checked every 6 months as to whether or not they're eligible for the program, which means that eligible kids are not kicked off repeatedly multiple times a year, and they're able to receive their coverage, for the entire year. So I would say those were 3 really big consumer pieces that were important for our populations.
Those are great examples,
yeah.
Lindsay.
Yeah, and I'll add on, without a doubt, for us, a huge issue was dealing with the 6 months eligibility for pregnant women. We were sad that it didn't end up being the full 12 months, which is how it left the House, and ended up being 6 months in the Senate. But I have a strong feeling everyone's going to show back up to try to get that extra 6 months next session, along with the 12 months continuous eligibility for children. Our organization really looks at 2 things. One, getting more Texans access to coverage, right? We have 5 million Texans that are uninsured. So we try to find solutions around that. And the second part, that it's affordable. So dealing with these price pieces. And I think there's some, really interesting things that are not great, but interesting about Texas when you look at research that shows that, of course, healthcare prices are out of control throughout the United States, but in Texas, we specifically have something going on we shouldn't compared to the rest of the country. So for example, health coverage this last year went up 13%. The rest of the nation, it was 0. We spend more on prescription drugs. We had, at the time when we had surprise billing happening, we were the worst state in the country for surprise medical billing. So we've got all of these different issues. Hospital prices in Texas are double what their cost reports are. So we've got all these types of issues happening in Texas. And there were a number of bills and discussions around trying to change this. And I would say a big one was all of the price transparency bills that have been going through the federal government, but now have passed through Texas. both price transparency on hospitals that will allow this information to be available. And then in June, the health plans are required to post these machine readable files that for the first time ever is going to have all of these negotiated rates and everything out there. So there was a huge push. In addition, the all payer claims database, which UT is housed at UT, for this. So real big push around transparency. While it doesn't solve all of these problems, we're real big believers that the first step of solving a problem is having the data to understand what the problem is and what needs to be solved. So you can't really get anywhere without information first. So we do think this is a really strong first step. There was some other very specific consumer pieces around these types of things. So for example, during COVID, we had a number of providers that were just price gouging consumers. I mean, I don't know if you guys, my favorite was when Kaiser had the article that said that there was a COVID test that was the price of a Tesla. It was a $30,000 COVID test. We had $5,000, $10,000 COVID tests for drive-through COVID tests happening. And so while this only applied in very specific situations, there was legislation that passed that made it, put some very hefty legal penalties around any type of provider that price gouges or basically tricks patients during a public health emergency around these pieces. The same way you would think about someone price gouging for gasoline during a hurricane, right? So very specific protections around protecting consumers around prices and the cost of healthcare.
Those are great examples, Jamie. And just for our listeners, before Eric has a chance to dive in, I do want to point out on the pregnant women's Medicaid extension that has been, 10 plus years in the making, and we made incremental progress, but I think the work is not done there yet. So I just want our listeners to be aware, getting it from 2 months to 6 months was a huge win, but I think we will continue to see that continuity of care issue be present in future sessions. Eric, what's most important for consumers from your perspective?
Well, obviously with COVID being what it was and the focus that was on that, what authority employers have, to check for their employees who are or are not vaccinated, what their role is there, as well as business operators and customers coming in. And, that's become kind of a politicized issue, but it was very much politicized during the Texas legislature as well. So we weren't immune from that. Ultimately, Texas, during the regular session, adopted a legislation that basically prohibited businesses from requiring customers to show that they're vaccinated as you come in the door. And having spent a little time overseas in the last few weeks, I know that that's not kind of how other countries address that. And so, that's an issue that affects lots of different people, lots of different ways. But that was a lot of discussion about that, certainly. And then kind of toward the end of the process in the special session, there was a lot of discussion about prohibiting employers from requiring their employees to get vaccinated, even in a healthcare setting. That raised a lot of concerns on both sides of the political aisle, and you had a lot of business coalitions coming together with providers and public health types. And ultimately that didn't pass. It kind of led to a whole lot of questions that there just wasn't time to answer. But those have certainly been, kind of facing patient-facing issues that are problematic, particularly if you have kind of immunocompromised relatives or what have you. On the mental health side, access, as you pointed out, continues to be a really big deal. And the legislature has done a whole lot over the last 5 or 6 years to expand the number of community beds, to expand state hospital capacity. It used to be that state hospitals were basically where people who needed mental health could go to get care. And now it is chiefly, those are places where forensic patients who are accused of committing a crime but are not mentally competent to stand trial, that's where they go to have their competency restored. So those are, 80% of the population of those facilities tends to be forensic patients trying to get competency restored. Texas tried to reverse that. They made a lot of investment in Austin State Hospital, the San Antonio State Hospital. They've laid the groundwork for Dallas State Hospital. We're continuing to look in North Texas and other places. So access to care in those facilities. Telemedicine certainly is a place where, you know, COVID exposed opportunities for people to get care kind of in a telemedicine setting. And there was a lot of discussion about how to do that. Was it appropriate to do that? What are the cost drivers for doing those kinds of things? We did it more or less on the Medicaid side. It hadn't been done as much on the commercial side. One thing I'll mention that Jamie and I worked on together is for a lot of patients, particularly patients who have mental health issues, you know, access to the medication, continued access to the medication becomes problematic. There's prior authorizations or other things like that. So the physicians that I work for and Jamie and a lot of the folks at her organization were able to work together, identify some places where we could streamline some of those processes, notify a patient at the point of sale when there's a problem, provide them with a supply of medication for the short term. Those are all things that I think will keep people on a path. Because if you get off your mental health meds, obviously that can present not only mental health issues, but a host of other problems, including homelessness, you know, loss of jobs, things of that nature. So that was a big win, I feel like, for people who are struggling from that standpoint as well.
These are all fantastic examples, way more than I would have come up with, and all make a tangible impact in the lives of consumers and families almost immediately. So again, work to do, but these are, I think there was some progress made in all these areas this last session. So now let's kind of flip this question a little bit and look at this from the provider's perspective. Were there big wins that you feel like, you know, whether it's a certain specialty or provider type, or just you want to speak more broadly, what were the key issues for providers in the healthcare setting?
Yeah, I think I'll start again from the provider perspective. For me, it was obviously funding the age drug assistance program to the level that it needed to be. I think I'm going to have to work on that again next session. So definitely not, it's going to be TBD, but I think another big piece for us was we have been grant funded from the Episcopal Health Foundation to place behavioral health therapists within our primary care setting. And that's sort of considered what's called the collaborative care model. And I think there were some major strides made with the bill that passed to allow for that sort of model to be reimbursable. That was a big step forward for us, just because we've seen so many patients coming in for their primary care visits, but there's clearly a behavioral health aspect of what is going on. And to be able to see somebody immediately, when I talk about the wait list that we have right now for behavioral health therapists, is a game changer for our patient population. And then the other two things I will say, and Eric touched on this a little bit, but further development of telemedicine is really important for us. So community health centers are largely a fee-for-service sort of model, right? You go in, you receive a payment. We're really trying to move towards a value-based care model, which is that I am attributed this patient and I'm attributed that they are healthier by the end of the year. That is very difficult in a setting like a community health center. And so telemedicine is going very much, that our organization believes that telemedicine is going to bridge that gap, so that we want to take on the responsibility of the health outcomes for that individual. And I say that that's important, but also teledentistry was really important. If you look at emergency room visits, it's sometimes a toothache, and we can manage that process through a teledentistry visit much earlier, so that we avoid an emergency room visit that is in the thousands of dollars versus a much cheaper teledentistry visit. And so I would say that along, coupled with being able to do remote patient monitoring, so we can do your blood pressure cuffs at home, we can monitor your insulin, we're going to really move in a direction where we're improving the overall health outcomes, and we want to take responsibility for those patients. And so just using technology to avoid emergency rooms for us is a game changer for our patient population. And to be honest, a lot of them are just completely transportation insecure. Every single one of our facilities is along a bus stop, and that's how a lot of our patients get to our facilities. But we've found that they do have smartphones, and they are able to absolutely access care through a computer and through a smartphone. And so just putting those out there, that those are the things that have helped the most.
Yeah, great examples. I was hoping we'd spend a little more time on telemedicine, so thanks for that. Jamie, thoughts from the provider's perspective? What were some key issues?
I mean, I do think telemedicine and the huge investments in broadband statewide. I mean, so, it's still going to take a while for all this to get spent in these pieces. But, in the pandemic, our plans really came to understand that a lot of hospitals in rural areas may have had access to broadband, but the people in their homes did not. So it was one thing for providers to have access, but they couldn't actually reach their patients with it. And it was a real problem also in urban areas. So it was, it really created a healthcare disparity issue. But there were so many solutions around both telehealth, telemonitoring, broadband investment. I feel like this was a huge issue for the session. For improving care and access for patients and helping providers create that bridge. And we, another big part of this that particularly to us is now we have the ability to text Medicaid patients, which we really couldn't do before, to help them, remind them that they have that doctor's visit, that they need to have that well child visit, that they are needing to get that immunization done, that, they need to have that prenatal visit happen on these pieces. So there's a real huge opportunity for, and really communicating with patients. And I know providers have the same issue, but we have all found that this is texting is the preferred method of communication for our enrollees, our clients, and the patients that providers are seeing. So those are really big issues this session.
And I'll mention we had more money than we anticipated, chiefly due to federal funds. So there was there was continued funding of G&E. There was maintenance of early childhood intervention programs, which have not always been maintained. CPAN is a big deal in the psychiatric community. You may be familiar with that, but that links psychiatrists with pediatricians generally to increase mental health care. That was fully funded, actually increased funding. So that was a win. A lot of money spent on workforce shortages. There's kind of back and forth about whether everything we did was the right thing to do, but there was a lot of money spent by the state to try and bridge the COVID, time period, and there was federal money that was made available kind of late in session that kind of repaid those funds, replenished those funds, and continued some of those efforts. A couple of things that the physicians that I represent care a great deal about. One is Medicaid rates. The pediatric providers that I work with feel like it's been an awfully long time since we've had pediatric rate increases for physicians, and lots of costs have gone up since then. Pediatric or Medicaid rate increases tend to be an expensive cost proposition, and so we're working on ways to make that a little more palatable, to demonstrate some savings that increasing access in certain areas is going to mean that you may not be in the NICU as long, or that you can get access in your community rather than having to go to Houston or Dallas or wherever. And so those are some places where savings might materialize, and the Department of Health and Human Services is reviewing some of that data right now. So we hopefully we'll have some progress on that. One thing that was real important to doctors, and Jamie may disagree with me that this was a win, but there was a gold carding legislation that passed that was meant to, from the physician perspective, if you're basically doing the things that keep your prior authorizations approved time and time again, north of 90%, that might, the argument is that ought to reduce your obligation to go get those as a matter of routine. That was not as favorably received by some of the plans, and that's kind of been back and forth, including at the agency, which is just issuing some rules right now. But certainly from the doctor perspective, that was important legislation this session.
Great, thank you, Eric. And also thank you for mentioning CPAN. I think that's selfishly, from UTHealth's perspective, that is a huge development in the mental health space and from both consumer and providers perspective. So maybe we could even put a link to CPAN up in the chat in case students or faculty are curious about learning more about that. But UTHealth, as well as the other academic health science centers, are all big players and hopefully making a difference there to increase mental health access. So we're going to shift gears slightly. So we're talking about all of these critical issues for the here and now, for the daily treatment of healthcare and patients and consumers. And sometimes it is hard to be forward thinking when we, as the state, to stop the here and now conversation, but to plan for the future with research and new developments and new technologies on the horizon. So I did want to include a question for so many of our students do work in that space and development and research. So what do you see as some of the big policy areas with the biggest potential for new research and exciting new developments in the healthcare space?
Well, I can start off with what I consider issues that exist. That's kind of how I'm always wanting to come at solving problems. But I would say, I think one of the most persistent data points that we have that I don't know why we can't get better is readmissions back into hospitals around mental health. It makes, there's just got to be a way to deal with this or to understand what is causing that, what's driving it. There's some theory that it's access to the drugs after they leave. Is it this kind of visit? Is it this kind of monitoring? What is it that happens? But on this piece, but I just think there's significant room for changing patient lives and lowering healthcare costs when it comes to readmissions on this piece. On maternal health, we still have a huge number. We have huge, the plans are very much looking into disparities in healthcare and health equality. We are very concerned about this. What is the driving forces around this? I think there's a huge amount of room to understand. I'm a registered nurse. Many of you are in different kind of provider education programs right now. What is it that needs to be happening at a provider education level that helps deal with these issues and help deal with them? And when I really talk about maternal health, I think in the last week there was some research published that because moms actually saw providers less, preterm births went down, and so did inductions, and so did C-sections. And those are the types of things that always, you're just sort of like, what? And it almost makes you a little sad that seeing a provider less resulted in a better outcome. And so, more research is needed. Why did this happen? What is going on this? What do we need to do to really lower preterm births? Once again, changing patient lives, because these babies that are born preterm, it impacts them for the rest of their lives. There's so much research on this. And two, neonatal intensive care is one of the most expensive healthcare that happens on these pieces. So I just think there's some really interesting things happening where there's huge amount of opportunity to both research and follow through practical solutions for dealing with many of these things that we see all of the time, that we know there's got to be a way to do it better.
Yeah, and I would say if I'm forward thinking, I would love to further the conversation around non-medical cost drivers. So for instance, at Legacy, we have an entire office that we're funded by currently an AmeriCorps grant. which is interesting. Most AmeriCorps staffers do not work in the healthcare setting, but we have 30 individuals that sit at our clinics and screen for food insecurity, housing insecurity, utility insecurity. That's a big one. So if you can't afford your light bill, as well as housing insecurity. And they spend a lot of time connecting, the kind of taking on as a case, connecting the individual to services that will overall help them feel stable in order to access their health care. Because if one of those pieces is missing, the likelihood that the individual is going to remain in care and continue their preventative care and not end up in an emergency room is likely. I would love if there was more studies done. I think you're seeing a lot of insurance companies adopting this model as well, that you address kind of the whole person rather than just their healthcare, because at the end of the day, it's going to save money. And I would love it if we can study that more and have more research. I've got my own research that's been that we've collected, but at the same time, it's really important to see the insurance side of things too, because I can't really see all the time when one of my patients goes to an emergency room. I'm not always getting that feedback loop. And so as we look to potentially, coming up with solutions for cost drivers, I think one of these things is good. I would love to explore that more next session.
Absolutely. And everything you both are saying on that topic is you're speaking the language of all of our population and public health students that are watching right now. So
Go public health.
thank you
Yes.
thank you for
I'm here
mentioning that.
Yeah.
Eric, what thoughts do you have on innovation and research?
Well, I totally want to agree with Jamie's observation about mental health readmissions. That is a huge issue, and that kind of drives. There's just a small population, and often that ends up driving a huge part of the cost. And it's not only hospital readmission, but also jails and homelessness and other things like that. There's a total community cost for that. And, there's a variety of reasons for that. I think, a lot of times the medications are they don't make you feel good, and they address your mental health issues, but they have other side effects. And, we give cancer patients medication, their hair falls out. That's an unfortunate side effect, but, people are willing to do that in order to, have better care. This population has been harder to treat in that regard. And so there is a lot of that goes around. But, more broadly, I think there is an opportunity for Texas to become really a center of innovation on all kinds of different things, not only medical, but all kinds of different cell and gene therapies, vaccines, getting into climate research and other things like that, sustainable farming, low emission fuels, animal feeds, things of that nature that start to impact the environment. And a lot of that stuff has been done historically in California or in the Northeast, but you're starting to see kind of a coalition of thinking that Texas is the next big horizon for that. Obviously, Houston and the medical center is a place where that kind of research has been done for a long, long time, and patient trials take place there. But in Dallas, they're starting to repurpose some of the facilities that have done, like, let's say, oil and gas research into kind of a J-Labs approach for innovation. Austin now with Dell Medical, that's driving a lot of thinking. There's access to the capital and other things like that. So really that kind of triangle corridor is starting to become a place where venture capital and other kinds of investors are saying, hey, we don't need to just look in the Northeast or in North Carolina or in California. Texas is a place where this kind of innovation can take place. Secret's another great example of the state's willingness to invest in that effort. So I do think kind of continuing to be the economic driver for those things is an important role for the state to play. Candidly, they're not always eager to play it. There's a fair number of lawmakers who feel like that's the private industry's role. We're not going to invest state dollars in that. but you're competing with other areas of the country, other areas of the world that are making those investments at the state level. So I do think that's a place that Texas is going to have to continue to be forward thinking if they're going to want to compete on a national and international scale.
That is an excellent point, Eric. It actually allows me to make a quick plug for mental health research. As you know, we've worked on this last session and hope to work on this again next session with Symphonia Thompson and some other members. But CPRIT, I think, is a really interesting model to replicate when it comes to not just mental health, behavioral health, but all brain research. So, be on the lookout perhaps for legislation or policy on that. And to the extent students are curious about that, we're happy to provide some follow-up.
I was just about to bring that up, Kara. I was like, you guys are at the forefront on this one. Absolutely.
Well, and it will take a village, though. I mean, obviously the brain is the most complex organ and we know the least about it of any organ. So I think it will take a lot of, whether it's investment from private industry or HRIs collectively, it'll take a broad focus. So maybe this is a good segue to our final question, and then we will leave some time for Q&A through the chat function with our students. But without giving away, too many trade secrets or what's in the works for next session, what do you see as some of the biggest policy issues that we're not shorn up, we're not finished last session that we have to tackle? What will be the priorities for next session that you're already kind of starting to work on and talk about?
I can, a lot of what we're trying to talk about is what we've just seen. The House issued an interim charge to a select healthcare reform committee. That's probably when I talk about dealing with my two sides of my issue, which is affordability, cost, these pieces, and then also looking at coverage and access to care. So I do know that, that'll continue to be a huge focus for us. We are very concerned about the entrance of private equity into healthcare. You can read a lot of articles, sort of the private equity takeover, how much prices suddenly inflate as a result of that, and what's happening to Texans and Americans across the way as we're looking at this. So we're hoping to see more solutions, expanding the price transparency kind of solutions, looking at competition, consolidation, marketplace issues that are dealing with this. And then with that, trying to still find more ways to provide coverage. People do talk a lot about Medicaid expansion, but that, while important, I'm not gonna say it's not important. It would only cover about 700,000 Texans out of the 5 million. We've got almost 700,000 children that are actually eligible, but not enrolled, that are in that uninsured population. This week, the family glitched announcement by the Biden administration, that has the potential to cover 700,000 Texans too. And we've got another 2 million Texans that are almost eligible for low cost and no cost insurance on the market, if we're doing a good job educating consumers and telling them about it, which has not necessarily been the case in Texas. So we think there's a lot of opportunity for coverage in Medicaid and the commercial market and assistance that already exists if we just are, being more proactive and helping with that. So, that'll be a big part of what we're talking about, in addition to trying to solve that gap population, that Medicaid expansion population.
Yeah, and I'll just jump in. I think we're definitely aligned on trying to solve that Medicaid gap coverage issue. The same committee that she's referring to, the Healthcare Reform Committee, has a charge around how do we get more folks into preventative care and increase access to preventative care. I very much believe that community health centers are a huge solution to that. And a lot of people don't know that we exist. So it's my job to let people know that we exist. We had some success in the final hours of last session with funding what's called an incubator grant, which is to kind of bridge that gap when you are a charity clinic and you want to become a full-blown federally qualified health center. It's very expensive to do that. And this would be a fund to help folks transition into a federally qualified health center so that we can get more folks online in underserved parts of the state that can treat the uninsured and do so with preventative care. So just talking about opportunities, how we can increase our reach across, Southeast Texas will be something that I focus on, as well as talking about those non-medical cost drivers.
That's great. Thank you.
I'll mention a few things. One is hospital funding. The 1115 waiver that got approved conditionally by the Biden administration recently. There are some local funding elements to that have yet to be sorted out. Broadly speaking, the plan was to expand Medicaid and the state to put some money up for hospital funding that would be basically matched by the feds. And that's not been the way it's played out in Texas. And they developed these fairly unique local provider agreements that were meant to kind of offset some of the state funds. Biden administration has taken a harder look at that than previous administrations have. So that remains to be seen because that's certainly costly from the hospital's perspective. Speaking for the clients I represent, obviously Medicaid rates continue to be something that we'll want to talk more about. Of course, Jamie's point about Medicaid expansion or coverage of that population is, that's not a panacea. I think we all need to understand that. It's become a political issue as things like this tend to do, but, there are a lot of costs imposed on the state and local governments for dealing with people who are uninsured. Immunization policy, I do a lot of work on the pediatric side. I'm very concerned about what we see nationally. Perhaps a little silly in retrospect to think that COVID was going to present us an opportunity for people to re-embrace public health and vaccines. That seems to have not been the case. We've certainly seen in other states where there are efforts to erode vaccination rates, not just on COVID issues, but on all different kinds of things. We are very concerned about that and the direction that conversation is taking. And also gender affirming care. That has become a pretty political issue. We're going to see a lot more of that probably, in part, some of the issues that we dealt with last session about competing in UIL or maybe at the NCAA level. But we're going to see, what treatment modalities there are for that population come into question. There's litigation, certainly. There's an AG's opinion. There's the governor's directive. It's a conversation that's not going away, and we'll have to really think as a state how we want care for this population, treatment options to look, because I do think it's going to be something we think about for quite some time.
Yeah, absolutely. And Eric, I'm glad you mentioned Medicaid rates. We don't need to spend a lot of time on this, but that was one of the questions actually in our chat was, collectively, what can we as a state do since our Medicaid rates are so low and it is such a deterrent in some regards when it comes to access? Is there anything we haven't explored there to just get our basic Medicaid rates up?
Well, I happen to let others answer the question. I'll tell you the approach that we took. We looked at a lot of the outcomes that are the result of, in our view, inadequate number of providers providing this kind of care for this population. And, for instance, where you used to be able to get care in, let's say Round Rock, and facilities closed down because they can't keep them open because the rates are so low. And so that population ends up having to travel to Houston, and that travel gets reimbursed. Also, they, because they didn't get care locally, they might have become, more acute conditions that require readmission or lengthen their stay in a facility. Is there a way to say, well, if we had additional physicians treating this population in this setting, would we avoid some of those outcomes? And so we proposed what we saw as, a very conservative savings model that would offset what we saw as fairly modest state investment in pediatric rates for 0 to 3, all physician services 0 to 3. That was not successful, but the agency is now looking at it. I think we're going to have an opportunity to present more data. And I think, I'm hopeful that becomes I'm hopeful it's successful, but if it is, I'm hopeful that becomes a means that we could use to look at other, inadequate Medicaid rate structures. I don't think the state is ever going to say, here's just more money, do with it as you see fit. I just don't think that's the kind of state we are. I think you're going to have to document that care outcomes are better, savings are materialized in other ways, more physicians take it, increased access. And if you can do that, then maybe there's a shot. But I do think it's a two sides of the same coin.
That's a great point. Thank you. Lindsay or Jamie, did y'all have any thoughts on what we do about our abysmal Medicaid rates? Or do you think we've belabored this point enough?
No, I think one of the things that's hard in this is that, my plans are the Medicaid managed care plans. That as the state turned over the Medicaid program to them, they do negotiate some rates, right? But they can't just wholesale increase rates. So they don't have the option to fix wholesale into one provider group on this piece. I do know that they do pay substantially higher to certain provider groups and lower than the state does. And it looks different from area to area. But I think the weird disconnect on this is that elected officials are no longer a part of that rate setting and negotiating process. So they feel like they have no ownership of it. And that disconnect has led a bit to a lack of the need to analyze rates and are they appropriate or not. We used to 20 years ago, we used to have the conversation of what % those rates were of cost, what % of those rates were of Medicare, and it would be a whole conversation happening. And we just haven't had that anymore. I do think what Eric is saying is true. I think it's going to be really hard to show cost savings with it on these pieces. So I think a part of it is also showing the outcomes and the value that it really adds to the system or where it's at as part of that. But that is a real challenge that I assume it's not just us in Texas, that because managed care is more nationally, like how do you deal with this rate part? When I first started, the state would rebase rates. When I was a lowly young baby staffer working on appropriations, we rebased hospital rates every year to what they were supposed to be. Right now, I mean, to cost kind of somewhere in there. Now, I think we're like 50% of cost is what the state's paying, which is why we depend so much on the 1115 waiver. So the only other solution idea I've had on this is instead of, since the managed care companies can't do this without some direction, is the idea of the legislature appropriating a lump sum of money that's supposed to go to increasing access. And that for each area of the state, the managed care companies have to show which of the top 10 areas, whatever, that are the problem with access is the largest, and invest that money into that. Where could you get the biggest bang for the buck? And it become more of a block grant kind of thing to the situation, right? So the legislature gives this money over, here's $200 million to increase access to care, go find the right places. So for some areas of the state, it would be pediatric psychiatrist. I would hands down say that's probably the hardest thing. And speech pathologist. We do not, there's some very specific things that we do not have. But at the same time, we don't also have them in the commercial market. So we have the workforce problem happening at the same time. So I think it's complicated, but I do think whoever's thinking about this the next 5 to 10 years is gonna have to figure out how to get past that mental hiccup that the state doesn't feel like it has a role in rate setting anymore, but they are the ones that pay for it. Yeah. And it's a weird, complex way to try to figure out around it. But Eric and them are, like I said, they're trying to figure out something, but that's really the problem.
Well, and your proposal about, whether it's sort of a block grant approach to certain areas of the state to just increase that access to certain provider types, it's sounds like it is ripe for some graduate research. So hopefully our students were listening. I think that's a fantastic
Well,
idea.
So I will tell you this, as who I'm an expert at this. I can't tell you right now what percent of pediatricians are enrolled in the Medicaid program. And I can't tell you what percent of pediatricians are in a Medicaid managed care network. And I can't tell you a percent of those pediatricians, how many of them are actively having claims run, which means they're actively seeing patients. And is it consistent every month of the 12 months? We have all of that data. It all exists at the medical board, at HHSC, at dishes, it's all there. It seems like a really base piece of information would be to know who's actually in the program and not. And is there a problem?
And to your point, Jamie, what percentage of them are taking new Medicaid patients,
Well,
and what fraction of their patients are? Is it 5% or are they taking 75%?
Well, and you can see that all with claims, right? So you know the claims for new patients and you know the claims for existing patients, and you can run claims on what percent of these claims are of their practice. We have all of that throughout the whole state, but no one, I cannot for the life of you figure it out. I've asked, I've open records requested it. I've done all kinds of things. I've offered to pay for it, but
Well, I hope we have
I'll go
some
back to
really
my
smart students and faculty taking notes.
I'll go back to my price transparency. I don't know where there's an access issue. And then when there is an access issue, I don't know how much of that is a rate problem and how much of that's a workforce problem. But we should know that for every type of provider, but we don't.
Excellent point. And, great questions, I think, for
Nice.
further follow-up and discussion. We are, I think, actually running short on time at this point, but any final thoughts for our students? I cannot thank you enough for your insights, and on behalf of Scott and I and UTHealth, we obviously look forward to working and collaborating with y'all for many sessions to come.
Thank you. Thanks for having us.
Thank you. Yeah, this was fun, and look forward to working with you too.
Scott, any final thoughts?
No, just thank y'all. This is a great conversation.
Much appreciated. Well, y'all take care, and we'll see you before next session.
Thanks, everyone.
Thank you.
Thanks, y'all.
Woody.
Hey, okay.
Okay, we are going to fix this for the next one, right?
Yes. So that's where all my confusion was, is
Okay.
that, go ahead.
Okay, you know what? I don't care. It happened. I just need to be assured that this is not going to happen again. I don't care if we thought 6 months.
No, that's the fix. And we tried to, I thought the fix was in, but apparently not. So the idea is to have that same link.
Guess what? I don't care. I just need to make it work in September.
So,
whatever it takes, just this is the stuff I don't know. So this is what I am absolutely leaning on you. So 6 months. Okay.
No problem. Yeah. Yep.
Thank you.
So I'll for the next one, I'll explain everything and how everything will work, and it should be without issue.
Okay. So we have 6 months to work on it.
Right.
Okay. Talk to you later.
Okay. Thank you. Talk to you in a bit.